Hello, good morning, good evening, good night, or whatever your time zone may be. We're so happy that you've joined us for another NDD monthly live training session. This month, we are going through the FVC test on the Easy on PC spirometer. So we are so excited that you have joined us, and we're going to go ahead and get started. All right, like you saw when you registered for the webinar, in this specific training, you're going to learn the basics on how to enter your patient data into the Easy One Connect software, how to successfully coach a patient through the FVC maneuver, to how to understand the session quality and interpretation messages from the Easy One Connect software, a few tips and tricks on results, and then an open Q&A at the end with me. My name is Jamie Burgess, and I am a respiratory therapist and work as the Global Research and Training Director here at NDD. So we are excited to get started. You'll see in your toolbar that there is both a chat feature and a questions feature. Feel free at any point during the webinar to type those questions in there. Bianca's on with us today. She's going to be monitoring the chat and the questions throughout the webinar. So be sure if you have anything that you need to ask, be sure to type it in there. She'll be able to answer some of those questions in real time. Otherwise, we'll save those for the Q&A at the end. All right, I am going to go ahead and swap my screen over to the Easy One Connect software. This is the home screen for Easy One Connect. Your screen might look a little different. You might have your facility's information entered in the upper left-hand screen, but you'll see that we do have these four primary tiles right here on this home screen. Another good thing to note is down in the lower right-hand corner, you'll see an icon that looks very, very similar to your Easy on PC spirometer, and that icon just indicates that your PC spirometer is plugged in and it's ready to use. Right next to that, underneath the little question mark, you'll see that there are some instructional videos for both technicians and patients on several of our tests that are available to view right within the software. And then you'll also see a full digital copy of the Easy on PC manual, also located within the software. Before we get started on the test, I always like to go through and hit some quick highlights on some of the settings and their location within the utilities menu of the device, just so that you can go in and make adjustments for your facility. All right, so to start, we're going to actually click on this utilities menu. Then we're going to click on this settings gear underneath configuration. And now you'll be able to see all of the different settings that we can adjust on the device, starting with general settings. Again, when you alter this to your name, address, facility name, phone number, not only will that show up on the letterhead of your reports, but also in that area on the home screen that we just viewed. Underneath the general settings, another good place to know about is the system settings. This allows you to set the default language, to select your units of measurement, to select how you want your patient entry to display, and those specific settings that are specific to the system itself. All right. Popping next over to the test tab, you'll see underneath general, there are lots of general settings on how you would like your reports displayed. Are we doing the ATS ERS best value, meaning from all the total trials performed, we're picking the best value of each of our different parameters. Below this, we have some optional settings like showing the ratio parameter in a percent, showing the Z-score numerical column, showing the predicted column. Again, these are completely your preference, but these are underneath that general tab. Popping over to our predicted value sets, how are we interpreting that this test is normal or not for that individual patient and their in a like demographics? And then how are we in choosing to interpret the test? So for spirometry interpretation, you'll see that there are options for adults and additional pediatric specific predicted value sets. Again, I have the global GLI 2023 selected as my selected predicted value. That is just showing of people of the same gender, the same height, the same age, what is normal for someone of my same patient demographics. And as you can see, there are lots and lots of different options to choose from. Some are very geographic, specific to certain countries, certain regions of the world. But again, for today, I'm going to have that new global GLI selected as my option. Same thing on system interpretation. There are several different options. If you would like the system to do an automatic interpretation of your test results, you can choose to turn this off. But again, for today, I'm going to have that gold hardy system interpretation selected. All right, staying underneath this test tab, I'm going to pop over to the test we're focusing on today, which is that FVC test. So I do have the FVC test selected as my preferred test type, and I am using the 2019 spirometry standard. You'll notice if you have updated your software recently that we've also added that post-bronchodilator that change compliant with the ATS ERS 2022 statement. And if you are wanting to follow along with that new guideline, like I am, you can have that selected here. All right, under each individual test, you'll see that there's a little bit of customization, both for what you see on the screen when you test and then also on the report itself. So if I go into my parameter select for FVC, you'll see that the two boxes on the left are what I see during the test, and the two boxes on the right are what I see on my report. You'll see that I have these 6 parameters selected out of a possible 55 different parameters. Same thing on my report as well. We can do a lot of customization here. So for example, if I really want to see, let's say my PEF, if I really want to see my PEF in liters per minute instead of liters per second, for example, I can select liters per minute PEF, kick it over to my report. I can decide it's the most important thing in the world and move it up to the top, or I can change my mind and decide that I want PEF in liters per second instead. I can highlight it and kick it back off of the report. So it's really easy to come in with your physicians and customize exactly what parameters you're seeing during the test and exactly what parameters they do want to see on the report as well. All right, just a couple of other things that I want to highlight here in the settings before we start talking about the test. The next tab over is the device tab. If you are like me, I go through stickers, I feel like a little bit quickly. So if the sticker is gone off of the bottom of your Easy on PC handle, you can come to the device tab and select your Easy on PC device to see the serial number. This is something that if you ever need to call into NDD support for any reason, a lot of times they'll ask you for the firmware version, the software version, and then that serial number of your device. So this is a good quick way. If your sticker has happened to come off of your device, this is a good place to come in and find that information. All right. One more tab that I want to talk about here underneath device is the inline filter tab. So if your facility is using an inline filter for spirometry, the only approved filter for the Easy on PC is the Easy One Filter SP, that stands for Spiret. This filter fits directly onto the back side of your NDD Spiret. And again, just because we are adding something to the mouthpiece, we need to let the software know that we're doing that. So again, for my Easy on PC, I have inline filter use selected. All that does, it doesn't mean I have to use a filter every single time, but checking that box will have the software prompt us before every test, are you using a filter or are you not using a filter? And then again, at this point in time, the only approved filter for the Easy on PC is that Easy One Filter SP. We had a temporary solution during COVID before developing, but at this point, we really do want to encourage everybody to be using the approved NDD filter. All right. Moving over to the report tab, again, there's lots of different customization that can happen on our spirometry reports, from general settings like showing the trial time, highlighting abnormal results. Right now, my abnormal results are highlighted bright pink. To trending reports for serial tests on the same patient. We can do that there in the middle. Printing lung age, showing our predicted points on there. And then if you're a customer that is doing an XML export, there's a couple of extra sections for that as well. If you've worked with our service and support to create a custom report for your facility, this would also be where you would come to load that custom report into your system. Last but certainly not least, printing. If you have a printer on network to your computer, whether it's physically connected or wirelessly connected to your workstation where Easy One Connect is installed, you should be able to refresh if it is on and ready to use, locate the printer that you want to select and use, and then you can just click save. Once you have that printer designated, when you click save on from the report page, that's the default printer that the device will send the printout to. All right. Again, a very, very quick overview of the settings, but I always like just to point out where some of these most commonly asked about settings are, just so that you guys feel comfortable getting these devices set up and customized for your use. All right, so now that all the adjustments that I would like to make have been made, I can come back here and I can click save. All of my settings will be retained and it'll bring me back out to the main menu. All right. The first thing we need to do before we start talking about the actual test is how to enter the patient information into the system. You'll notice that these buttons are all a little bit different ways to get to the same location. We can click on history. It's going to show us a list of recently done tests on the device. If we click on test, it's going to ask us which patient we want to do, and then we can either choose an existing patient or enter a new one. But for the webinar today, we're actually going to start in the patients tab. You'll see that every patient that's ever had a test done on the device is going to be located on this screen. If a patient is coming in for a subsequent test or serial testing, you'll notice that in the upper right-hand corner, there is a filter search where you can search by last name, first name, or their patient ID. All right, and then down in the lower left-hand corner, you'll see the tile that has the option to give a, to create a new patient. So that's where we're gonna start. I'm gonna go ahead and click on new. Here on this very first page of patient entry, the only things that 100% have to be selected are the items with the star next to them. So our patient needs a patient ID, they need a last name, they need a first name, they need their sex, they need their sex at birth. First name and last name is optional. Again, unless you have a necessity to anonymize your patients, it does make it easier to search them in the system if you do have a first and last name. Ethnicity, this is a question that we've been getting a lot lately because as you noticed, I did have the global GLI selected as my predicted value set, or as it's kind of commonly being called in the pulmonary community, the race neutral GLI. That is 100% accurate. That Bowerman GLI 2023 does not factor in ethnicity into the predicted values. However, to enter a patient in the system, it still has to be entered. So just so that there's no confusion there, if you're using the race neutral GLI and you don't want to put their actual ethnicity in here because we know it's not being figured, you can always have the option just to select other as well. All right. The date of birth, the height in feet, in inches or centimeters, depending on what you guys have put into your system. And then if you do put the weight in, it will calculate a BMI on the report, but the weight is actually not factored into those predicted value sets, which is why it's optional. All right. Some other additional patient entry tabs are smoking history. Is the patient a smoker? What's that history look like? Have they been diagnosed with asthma? Have they been diagnosed with COPD? Underneath the history tab, who ordered this test? Who referred this patient over for testing? Underneath the environmental tab, does this patient live at a residence of high altitude? And then an open text comment box for any other values that you might want to put in here. Some people will put vital signs in here or pulse ox in here or any other symptoms that you would like to show on the report that would help guide your overreader in interpreting those results. But again, the only things that 100% have to be filled in are the starred items on this first page. We can do a quick double check, make sure that everything looks correct, and then we can click OK, and now this patient has been created in our system. We always want to make sure that we are selecting and testing the correct patient. If for some reason a patient is tested on the wrong profile, unfortunately, that's not something that we can move on the support side. So always double check. You have kind of two quick double checks. Make sure that the correct patient is highlighted in your patient list. And then also in the lower left-hand corner of your screen, you will also see that patient name and ID before clicking over into the test, just to confirm identity. You'll notice that there is an edit button next to new. And a lot of times we go through examples of when we would need to use the edit button. So we'll just quickly cover a couple of those instances. So let's say you've realized that you've made a mistake. You quickly did your feet in inches, 2 inches wrong. That math, that's pretty common. And you need to change their height. That's all right. No harm, no foul. The patient has not conducted a test on the system yet. We can quickly edit this patient and click OK to apply that change to any test moving forward. The second example is there's been a change in your patient from the last time they did a test. So I'm going to click on one of my other profiles that does have tests. I'm going to go down here to the edit button. Now that you see that there's another button that has appeared, the update existing tests button. So if this is a change that would only affect tests moving forward, so let's say the patient has either lost some inches in their height, we had originally entered a weight in a patient and the patient has lost 100 pounds, we don't want to change any of the tests that they've already done on the system. We only want to change tests moving forward. So again, we would make our change, and then by clicking OK, we're only affecting tests moving forward. The update existing tests button exists for when we have made our mistake, tested the patient, and the patient's in their car driving home, and we realize that we need to recalculate the results based on their correct patient demographics. At that point, we could come in and make our change and then click to update existing tests. As you can see, this particular patient has several tests on their account. So I would pick a test that I would want to change, the one that maybe we entered the wrong information, or if they only have one test, of course, we could apply the change to all the tests. We would update the value, which again, I'm pretending a little bit here. We would update the value that needs to be updated and then select to update the selected test or all tests in the system. Again, most commonly, this is when we have entered a patient's height wrong, something looks a little fishy in their results, and we need to go back and apply the correct measurement to that patient's results. So those really are kind of the three instances that we use that edit button once a patient is already entered into the system. All right. So I'm going to go ahead and go back out, select my patient again, making sure that I am testing the right patient at the right time down in the lower left-hand corner. And now I'm going to go ahead and click test to take us over to the test menu. All right. I'm going to stop sharing my screen here for just a moment so that I can be a little bit bigger in your screen. So before we get started with the spirometry test, we're just going to talk a little bit about what kind of preparation is needed. Sometimes we know that patients are getting spirometry tests when they come in, either they have respiratory symptoms, we test them once a year for an existing condition, whatever that might be. And there might be clear instructions from your providers to give these patients when setting up their appointment. Some providers will want certain medications held. If a patient can go off of their home oxygen and maintain their oxygen saturation for the duration of the test, instructing them what kind of clothing to wear, making sure that they're not wearing anything too tight, too restrictive. Again, some of these things, if we know the patient's getting a test, we can relay those instructions to them from the start. But again, we don't always know that a patient's going to get spirometry. Sometimes when they present in our clinic, their symptoms make something in us go, we probably need to talk to the physician about doing spirometry while they're here. So some things we can't always plan for, but certain things we can adjust at bedside. Making sure that the patient's in a good stationary chair with both feet on the floor, sitting up nice and straight. Making sure throughout the entire test that they have good posture, that their chin is elevated off of their chest so that they're not closing off their airway. Making sure that any tight-fitting clothing is loosened. Things we can't see, abdominal binders, chest binders, girdles, suspenders, neckties, anything that would prohibit them from taking that biggest, deepest breath possible and blasting it out as hard and as fast as they can. Another question that we get a lot is about dentures. If dentures are well fitted, it is recommended to leave them in place because the patient can get a much better seal on the mouthpiece with those left in place. But if they are too big, too small, not secure, obviously then we would have the patient remove them so that again, they can make a better seal on the mouthpiece. I always tell people that even sick people can do a spirometry test correctly. When we talk about the quality of a spirometry test, when we talk about, is this parameter usable? Is it an A grade at the end? Is it a B grade at the end? I always like to tell people that has nothing to do with how sick the patient is. That is actually only looking at how well or how poorly the test is performed. So even sick people can do quality spirometry tests. And that takes good coaches to be able to walk them through that. No one breathes like we do in spirometry naturally. No one walks around naturally doing an FVC maneuver. And most likely, if they've never done spirometry before, they're not going to know how to do it correctly without us explaining it to them and demonstrating it for them. This is a difficult maneuver for patients to do. Even healthy patients sometimes can struggle understanding exactly what is expected of them during an FVC maneuver. People on the call that are familiar with shapes and curves, you guys will see that I do have asthma. Even on really, really good lung days, I'm still going to present like an asthmatic when I do my spirometry test. However, I can always do a good quality, session quality A grade test that is repeatable, that is acceptable. Again, those grades are not how sick the patient is. Those are how well they can perform the test. So to get started with the test, even if you're doing an expiratory only maneuver, we do recommend that every single patient uses nose clips. This just prevents any air from coming through the nose that otherwise would be blasted out through the spirometer. We don't want to underestimate any of our volumes in spirometry just because we're leaking out of the patient's nose. So again, for inspiratory maneuvers like SVC, the FVL test that completes the loop, multiple breath washout, DLCO, we 100% require nose clips for those maneuvers. But for FVC, even though it's only recommended, again, we strongly recommend it just to make sure that you are capturing all of the air that the patient's blasting out. You'll also need your single patient use Spirette mouthpiece. This, just like I was talking with the filter earlier, the NDD Spirette is the only approved mouthpiece for this spirometer. So you do want to make sure that you are using the NDD Spirette and the NDD filter SP if you're using an inline filter, just because we have thoroughly tested these and we know that these are the best option for our device. And as I mentioned earlier, if your facility does require inline filter use, you will also need that filter, Easy One Filter SP that fits onto the back of your Spirette. All right. To get set up for testing, you'll notice that on the top of your spirometer, there is a stamped arrow. And it is, I have colored mine with a Sharpie. Yours will be white and match the rest of the Spirette. But you'll also notice that there is a stamped arrow on the top of your Spirette as well. When you put the Spirette into the Easy On PC, those two arrows should match all the way up. All right, you can only put the Spirette in all the way one direction. If you happen to have it in there upside down, the software will give you a Spirette insertion error and tell you to check your setup. So always just making sure that arrow to arrow, those are all the way in. If you are using the Easy One Filter SP, the Easy One Filter SP then goes on the back side of the mouthpiece. Just be careful when you are putting the filter on that you don't pop the mouthpiece back out of place, because again, you'll get that filter, or excuse me, that Spirette insertion error, and it will ask you to check your setup. So making sure that the filter is on nice and snug, but that you did not pop out your mouthpiece from its arrow-to-arrow position. All right, today, since I'm here, I'll go ahead and test with the filter for you guys today. And then you'll also have, of course, your nose clips. So when we're instructing our patients to do this test, we instruct them to make a good tight seal on the mouthpiece, making sure that their lips are not in the way, that their tongue is not blocking the mouthpiece, that they have their teeth on the top and their tongue on the bottom. We're going to instruct the patient to take a big, big, big deep breath in and then immediately blast it out as hard and as fast as they can. We're going to have the patient keep blowing and keep blowing and keep blowing until they reach the point of expiratory plateau, meaning no more air is coming out of their lungs. Your patients will feel like they are out of air before they are out of air. the system will actually end the trial automatically when it senses that point of plateau or that no more air is coming out of the patient's lung. So until you hear the audio cue to stop the test, we should be encouraging our patients to keep blasting out air. Again, this is a really, really hard maneuver for patients to do. We can tell them to blast out as hard and as fast as they can. Sometimes we have to demonstrate it for them on our own spiret, being able to show them what to do. A lot of times patients will say they can't blow anymore, or I was way out of air. We can show them on the screen actually even that there is still air coming out of their lungs, that we need them to continue to push and squeeze that air out of their lungs until the software ends the trial for us. All right. When we do spirometry under the 2019 ATS ERS new standards, for each individual trial, we're actually looking at FEV1, how much air they get out in the first second, and FVC, how much air they got out over the entire trial. We're looking at those separately and calling them either acceptable, usable, or not usable. And in our software, we have that designated with kind of a stoplight smiley system that you'll see when we get into the test. That really does give us a detailed breakdown of what went right and what went wrong in the test so that we can coach them better or more efficiently on the next trial. With spirometry, we have to have a minimum of 3 acceptable and reproducible, meaning one trial looks like the next, trials to be able to end our session. We should continue to add trials until the software tells us that the session is complete with an A or a B letter grade. All right, so I'm going to go ahead and pop back over to the EZ1 Connect software. I have myself still down here in the lower left-hand corner. I am confirming that I do have myself selected as a patient. And I can go ahead and then click on this FVC button. The first thing it's going to ask me, am I using that EZ1 Filter SP or am I not? For this example today, I am going to use the EZ1 Filter SP. The next thing it's going to instruct me to do is to block the spiret mouthpiece until prompted to blast out. So we can either leave the plastic on the front of the mouthpiece, use a gloved hand to either side, just so that no air is moving through the chamber. So this point-to-point ultrasound can do a quick baseline setting to 0 prior to starting the test. So I'm going to block the end of the mouthpiece with my hand. I'm going to click OK. And then the coaching bar is going to turn blue and tell me to start the test. So again, teeth on top, tongue on bottom, big deep breath in, blast out as hard and as fast as you can until the software tells us to stop. Awesome. All right. So you'll see your flow volume loop on the left-hand side unless you have an animated incentive selected. And then you'll see that volume time curve displayed in the middle. The volume time curve is a great place to watch as the patient gets closer and closer and closer to that point of plateau to be able to see that air is still coming out of their lungs, even the littlest tiny bits before the session is ended. If you've been doing spirometry a long time, you'll know in the previous set of spirometry standards in 2005, we used to have this magical 6-second number that the patient had to blow out a minimum of 6 seconds. A lot of people were stopping the trial at 6 seconds no matter what. Again, we always wanted to get them to that point of expiratory plateau. And so that's why that minimum time of 6 seconds went away with the 2019 standard, because we really want to make sure that we're using the correct verbiage. We want them to blast out until there is no more air left in their lungs. For some people, that can be 4 seconds. For some of our more obstructed patients, that could be 12 seconds. We can manually end the trial at 15 seconds if the patient is still blasting out. All right, a few things to take a look at on this screen here. You'll notice I do not have an incentive selected. We do have the birthday cake. We do have the elephant. I'll do a couple of those trials so that you guys can see those here in just a second. But if you select no incentive, you will see your flow volume loop during the maneuver. Down below here, you'll see that I do have the Global GLI 2023 selected as my predicted value set. And then those 6 parameters that I selected in the utilities are showing my results here in the lower left-hand corner. I only have one trial, so of course my best is everything from this trial because that's all we have to go on, followed by the lower limits of normal for this patient, followed by the numerical z-score, the z-score plot, the percent predicted for this patient, their actual predicted value, and then my green trial number 1. All right. Don't be alarmed with my ratio being a little bit low on that 81% and my 25/75 being a little bit lower. Again, I am asthmatic. These are pretty normal numbers for me. All right, I'm going to flip back over to my slides here for just a second because it's a little bit easier to see. When I click on this green smiley face, it really does give me a good detailed breakdown of why this trial is acceptable for both FEV1 and both FVC. So I'm going to show you guys a little bit different breakdown of what that can look like. All right. So looking at this 2019, where we individually evaluate FEV1 and FVC, so that green smiley face is indicating that both FEV1 and FVC are acceptable. The yellow smiley face indicates both parameters are at least usable, but they're both not acceptable. I will show you the most common example of this in just a moment. The most common example is to have an acceptable FEV1. That patient blasted out hard and fast, but then they stopped before they got all the way to expiratory plateau, so their FVC is only usable. That is the most common yellow stoplight smiley that we see, is when those patients have a great start to the test, but then just don't finish it all the way to the expiratory plateau. And then obviously our red, very sad smiley face is at least one of those 2 parameters, FEV1 or FVC, is not usable at all, right? And you will actually see those examples as your trials build across on your screen. Right? Again, we just took a look at this screen. This is that example that I was just talking about, where we have a good FEV1, the patient blasted out hard and fast, but then they did not make it to the point of expiratory plateau, so their FVC is only usable. Again, it does show us that detailed pass-fail criteria within the software. It gives us some recommendations for manual checks. And again, we can, as technicians, reset this trial or delete this trial or rearrange these, rearrange whether something is acceptable or usable. However, our software follows the ATS ERS standards to a T. So if we are coming in and manipulating results, we need to absolutely be leaving notes for the people reading our results, to our physicians and our overreaders, why we made that change. Right? So we talked about what makes an acceptable trial, what makes these little green smiley faces green. And there's just a few different things that ATS ERS recognizes to be for a test to be acceptable. The first one in this trial quality is an explosive start. We want to make sure that after the patient takes their big deep breath in, they are blasting out as hard and as fast as they can to make sure that that FEV1, or the air that comes out in that first second, is their best effort. We want to make sure that the BEV is less than 5%. So we want to make sure, you can kind of see on the graph here, we really do want to make sure that it is an immediate blast out, hard and fast, from our patients. We also want to make sure that there's no glottic closures or abrupt stops to the trial. So as I mentioned earlier, we want to make sure that the patient maintains good posture during the test, including keeping their chin off of their chest. So many times, if we tell a patient to take a deep breath in and then blast it out as hard and as fast as they can, they curl themselves up into a little ball, just like that. In doing that, they really are restricting their airway and cutting off the amount of air that they are able to blast into the spirometer. So we really do want to make sure that we are monitoring their posture throughout the test and encouraging them to stay upright in subsequent tests. Now, are there some anatomical things that can cause this without it being posture? Absolutely. But 9 times out of 10 with these patients, it's going to be something that they have physically done to shut down their airway. We especially want to make sure that there is no abrupt stop within the first second because that again will affect our FEV1 pretty significantly. All right. So again, we want to encourage these patients to keep blowing while maintaining that good posture during the test. A cough. So this is something else that happens really frequently. We tell somebody who might already be coming in with respiratory symptoms to blast out as hard and as fast as they can through this tube. Sometimes they are going to cough. And while some patients can recover from a cough, and after the first second, again, after FEV1 is captured, our software will also recover from a cough. But a lot of times it's the more we cough and the more they're trying to blast out to not end the trial, the more difficult it becomes and the more likely they are to keep coughing and keep coughing. So normally after a cough, even if it's after the first second, it's best just to stop the test, give them a drink of water, and then move on and try that trial again. All right, extra breaths. We always think about extra breaths in maneuvers that have that inspiratory component, which is why, of course, we always recommend nose clips. But patients like to be really sneaky. They like to think that they are cheating this test somehow, and we will actually see these extra bubbles of breath during the exhalation. When someone feels like they are running out of air, that they can't push out anymore, they might try to sneak tiny little extra breaths in, just to kind of cheat it, to kind of make the test go by faster, they think. Again, we don't want extra breaths, especially after, especially in the first second, but we don't want them taking extra breaths. We need to emphasize to these patients, this really is a single breath maneuver. One big breath in, one blast out. No extra breaths to try to get us through. All right, we talked about how we have to have a minimum of 3 acceptable and reproducible trials. So what does that look like? We talked about things that make a trial acceptable. What makes the trial reproducible now? And for adults people over the age of 6, that repeatability for FEV1 and FVC is reached when the difference between the largest of those values is less than 0.15 liters. And we actually do show the variability on the session quality section of our results screen. That is also a common question that we get with this new 2019 standards, is people will see that they have 3 green smiley faces. Why in the world isn't the software ending their session? It's 3 green smiley faces, that should be it. The next step is always to go and then look at that session variability. Normally, it's going to be outside of that range to give us an A or a B grade, which is why it wants us to continue to add trials until the trials all look the same. Here is that session quality grading chart. Again, this is not NDD's grading chart. This is straight from the 2019 spirometry standard. And again, to finish a trial with an A or a B grade, looking at A as an example, we have to have 3 or more acceptable trials that are also within 0.15 liters of one another for kids or for people over 6. You'll see down where I have kind of the red highlighted box. That is what displays on your report and on your testing results screen. You'll see the FVC and the FEV1 variability listed. So if you're staring at 3 green smiley faces, wondering why your session is not being called complete, your very next spot for your eyes to look is to see what the session variability is, because most likely that is what is keeping the session from completing, is that repeatability. All right. All right, we are going to hop back over to the EZ1 Connect software. I'm going to do another trial for you guys. All right, teeth on top, tongue on bottom, big deep breath in, blast out immediately on the mouthpiece as hard and as fast as you can until the software tells us to stop. Awesome. So now I have 2 green smiley faces. You'll see that my FEV1 and FVC session quality grade is now a B because I have 2 acceptable trials within the appropriate variability. Again, we always want to make sure that we have 3 per the standard. All right. I'm going to go ahead and swap this over so we have an example here with the birthday cake. All right, I'm going to add another trial. And then this is actually an alternate view. As you guys can see, We can have the view with just the birthday cake and just the volume time curve, or we can rotate it around so that we can see the birthday cake really big and both of our graphs, which is what I prefer when I use the incentive. Here we go. Awesome. So they need to keep blowing until that last little stubborn candle gets blown out. All right. You'll see that it is giving me the message that the session is complete. Great job. We want to, again, continue to add trials until we get that message of session complete. Great job, with a session quality that is that A or B range, meaning not only are the tests acceptable, they're reproducible as well. All right. One other thing to look at here on our screen is the area over here to add a comment. So if there's anything that needs to be added to our report, this can be if you're doing pre and post bronchodilator testing after this initial pre-test, displaying your dose of your albuterol. This can be leaving a note for a physician, saying patient tolerated the test well and without issue. This can be after 8 trials, patient did not understand what was expected. This provider ended the test manually. Whatever comments that you need to relay to your physician during the test, you can use this test comment bar to leave those comments to show up on the report. Anything that you think would be helpful to the physician while they are interpreting these results. All right. Again, you'll see here in the middle, I do have that session quality of an A grade on both my FBC and my FEV1. And then you'll also see, because I did have a system interpretation selected, it is saying per the Gold-Hardy standards that I do present with a mild obstruction, which fits because I am asthmatic. All right. All right, once we are done testing our patient, we get the session complete, great job. If you are already set up with your printer, you know the printout looks exactly like you want it. From this page over in the right-hand side, you can just hit the print button and print your report to your, again, if you've already got everything established, your printer's saved, the report looks like you want it, you can directly print. But to view the report before printing, we can click on the tile right above that that says report. In the upper left-hand corner, once it swaps over here, you will see that there are some pre-built templates in EZ1 Connect, a standard, a large flow volume loop only. Let me flip it over to the standard report here. Most everything is a change in font, a change in graph size, rearranging things slightly, but all of the reports contain the same core information. All right, so at the top, again, it would have your facilities information that you entered in the utilities menu. Below that is all of the patient information. Below that is your test setup information, the date and the time, what predicted values are you using, what interpretation. And then below that, based on those 2019 reporting standards, is the layout of the report, with our best values being reported first, and this is the best from all trials in each individual parameter. The lower limit of normal, our numerical z-score, our percent predicted, our actual predicted value, and then our trials, trial 3, 1, and 2. It's order from best, starting on the left. All right, again, for whatever reason, in a recent training, I decided to make my abnormals hot pink, so all of my abnormal values are being displayed in hot pink. Again, it's summertime in Southwest Missouri, guys. My ratio is going to be a little low right now. So that is normal. Below that is going to be our session quality so that our physicians can see that this is an A grade test. It's acceptable. It's reproducible. We can have really good confidence that this is an accurate test for our patient. The system interpretation for me, which is a mild obstruction. And then I am using that EZ1 filter, so we have that designated on the test as well. Below that is the graph representation of our z-score. So looking at the predicted values for a patient, the lower limits of normal for that patient, where do they plot? This is a really good visual for our patient. If their predicted value set is 0, everything better than that is healthy and fantastic. Everything below that, something that we can take a look at. All right. And then down below that, it's a little bit hard to see unless I zoom in. We'll zoom in a little bit here. Your graphs will probably not look so identical, but you'll see your three best trials unless you have selected any utilities to view all trials plotted on top of one another here in both the flow volume loop and the volume time curve. Again, I do spirometry all day long, every day, so my trials look nearly identical from trial 1 to trial 3 here. All right. Again, once you, if you have a printer connected, set up in the utilities, ready to use, from this page, you can just click print in the upper right-hand corner. If you are pulling your reports as a PDF to drag and drop in a database or into your EMR, whatever your setup might be, then you can click on print menu. You can do this export button. And again, most commonly exporting a PDF into a shared folder, an EMR, whatever your case use case may be. You can save this document as a PDF document. You can name it to your facility's preference and save it to the designated location. All right. When all is said and done, you can click return and then go back to your main menu, and you would be ready for the next patient. The easy one, the nose clips, the easy one filter, and the single patient use spirette. All three of those are single patient use and should be disposed of in the trash between patients. The handle itself can just be wiped down with an approved disinfectant, making sure that we're not actually cleaning inside of this tube. Our spirette has filters that protect the inside of the tube, so just wiping down the handle and waiting the recommended time between patients. All right. Well, I am going to go ahead and stop sharing that screen there for just a moment, so I'm a little bit bigger on your screen. And as far as the content goes, we've covered everything for that FBC test. So I'm going to have Bianca come on, and let's see if we have any questions we can answer in this last 10 minutes together.
Awesome. Thank you so much, Jamie. So I do have a couple questions here.
Yeah.
The first question is asking about deletion of certain tests and wondering if we can delete lower quality tests so it doesn't appear on the final report. So that's one question we have here.
Okay. Yeah. So absolutely. So I'm a big advocate. I very, very, very will delete even bad tests because you never know what could be hiding in a bad test. The rest of the test might be complete garbage, but it might have been their best 2575, or it might have been their best FEV1. Really, the only time I delete trials is if I have a trial that is a significant outlier that is affecting my reproducibility. Our test is, again, it follows ATS guidelines. It's only going to take your three best tests. So if you do 12 trials, it's still only going to do the best three. So the likelihood of that bad test being thrown onto the report is pretty small. And again, I always say you never know when you're going to have a parameter that might be the best, even if it's in a bad test. So again, if a trial is bad, you can absolutely mark it to unacceptable. You can throw it out. But again, you never know when you might need a parameter out of an otherwise bad test. And again, our software only takes the best three. So it really is preference, what you want to see on the screen as you're testing, because again, it's only going to take the best three to the report. So again, the only time I really delete is when I have a significant outlier that's affecting my reproducibility. But again, it's kind of a preference thing.
All right, perfect. I have some questions rolling in here, so I'll just move on to the next, Jamie. I
Sounds
do
good.
have a couple questions regarding calibration
Okay.
and the process and needing calibration if calibration is needed. So I do have a couple questions regarding that.
Yeah, absolutely. With our devices, they use a point-to-point ultrasound that is actually calibrated during manufacturing. So the device itself will not need manual calibration for its lifetime. This point-to-point ultrasound is not affected by environmental factors, temperature, barometric pressure, humidity. We can move this from room to room to room and have confidence that it is reading correctly. However, there are, depending on where you are in the world, depending on what patient population you are testing, There are some facilities even that require a periodic calibration check or a calibration verification. And again, ATS requires that for that to be done on a regular basis. So you can check calibration on this device as often as you need to per your facility's requirements. For an example, if you're doing occupational health testing in the United States under NIOSH, you have to do a multi-flow cal check or a calibration verification any day that you're testing patients with a 3-liter syringe. We have a really, really great video on our website that walks through how to perform the calibration check with a syringe. That's a little bit easier for me to demonstrate than trying to hold the syringe up and showing you guys here. But yes, if you need to check calibration, you can absolutely do that with a 3-liter syringe. But again, we're not changing anything in the device. There's nothing that we can do. If you look at the standard, we're considered a flow spirometer that cannot be adjusted by the end user. So again, all we're doing when we do that 3-liter syringe check is just verifying that on that time and day, 3 liters reads 3 liters at 3 different speeds. So again, if you need to do those cal checks, you can do them as often as you guys need to.
All right, perfect. I have a few more questions, so I'm just gonna keep going. I have a question here regarding the smoking information tab for patients that vape.
Oh, okay, so this has been really hot, and same thing with marijuana use. I mean, because all the standards are written for really is cigarettes. That's what we hear about. That's what we have the most data and the most literature on. My recommendation as a respiratory therapist is obviously, when we talk about pack years, when we talk about other things, those are not being applied to the predicted value set at all. So if I say that this patient is a smoker with a 50 pack year history, that is just additional information for our providers, different pieces of the puzzle for them to be able to interpret the test. Me clicking the box saying that they're smoker doesn't somehow change how we interpret the results. It's just, again, an additional piece of puzzle for the person reading the test. I have been recommending, because again, when we talk about pack years, we're really specifically talking about cigarettes, because again, that's where that data comes from. We have years and years and years of cigarette data. I absolutely encourage people to make a note of marijuana usage and of vaping, because as we know, there's more and more and more data coming out, and in another 30 years, we will probably see that just like we do smoking as far as how those pack years affect our patients. And so let me just quickly hop back to Easy One Connect here. When I enter a patient, a lot of times I will click smoker yes, and in smoking history, I will put that they vape, or that I'll put that they smoke X amount of marijuana cigarettes, or vape X time a day for how many years. Again, all of the data that we have on pack years, things like that, are so specific to cigarettes, but I absolutely will still say, yes, they're a smoker. And in the smoking history, I'll talk about those more specific or kind of outline instances like marijuana usage and vape. So that's how I've been kind of instructing people to do that. Because I mean, everybody on this call knows, we're going to see the same type of data in another 30 years like we did 30 years ago for cigarette smoking.
All right, awesome. Thanks, Jamie. We have another question here regarding your recommendations on having the patient sit versus stand for the test.
Yeah, absolutely. So in the ATS document, there's really no difference in a patient's ability to do the test standing versus sitting. Doing tons and tons of patients, having them sit, having them stand. There's really not a lot of data that shows that one is better than the other. We always recommend sitting in a stationary chair, just because this is a forced maneuver where we're having the patient push, push, push. We do not want the patient to have a vagal maneuver and fall over on us. However, there are certain patients that are way more comfortable taking that, they can move their chest a lot better standing up. I always think about morbidly obese patients, patients that carry their weight in their belly, pregnant women, people that sitting down would inhibit them from taking the biggest, deepest breath possible. They probably would have a better test standing. always just make sure that you have that stationary chair right behind them. Again, I'm asthmatic. I've done spirometry since I was 4. Um, I did official spirometry standing up 3 times, and it was the 3 times I was pregnant because there was no way I was going to be able to do it sitting with a baby belly. So again, really patient preference, but having a stationary chair right behind them if they do elect to stand, just on the offhand that they vagal, is always a good idea.
All right, awesome, great. I have another question here regarding some coaching tips for patients that do not
Okay.
speak English.
Yes. So again, if you are a native speaker and can coach them in their native language, obviously that is, obviously that is the most ideal thing. But I have had clinics where, it is the technicians and the staff do not speak the native language of the people coming in for tests. Changing the language in Easy One Connect changes those coaching instructions, which sometimes can make it easier for a patient to understand what to do if the coaching that they're seeing on the screen, where it says to, take a deep breath in, blast out, keep blowing, keep blowing, keep blowing, they can read those in their language if we swap the language on the screen for them. The other part of that is like the power of demonstration. When I come in to do trainings, I always recommend that providers have this is my mouthpiece that I can carry around so that you can show them on your own mouthpiece, not even hooked to the device or anything, but the power of demonstration in this one is huge. So, being able to switch those coaching messages to their native language and then being able to demonstrate on your own mouthpiece what's expected, most people have really good luck with those two things.
All righty, perfect. I think we've come to the end here. I have quite a few that I'm going back and forth with on right now, but I think
Okay.
I think you answered all of them. So thank you so much, Jamie.
Yeah, and I do get to see these questions when I kind of or when I'm able to pull the report from the webinar. So if somehow your question got missed, I will be able to see those when I pull the report from the webinar. So I can always reach out to you directly if your question did not get answered today. But we just appreciate you guys so much supporting these. Next month will be at a year of kind of revitalizing and relaunching these monthly live trainings. Um, we hope that they provide value to you guys. It's been really fun over the last year, kind of going through all the products. This is the start of one more cycle going through our products for 2024. The Easy on PC this month, moving back to the Easy One Air, then moving to the DLCO test, and then finally in October, wrapping up again with the multiple breath washout test. So we hope that you guys have found these useful. It's been a lot of fun being able to hop on with you guys every month and go through a different device and a different test. So I hope you found it useful. Please reach out to us if you guys have any questions or concerns about your device. Um, we'd love to hear from you guys, and we hope that we'll see you on another live training coming up soon. So have a wonderful weekend, everyone, and we will see you next month with Easy One Air. Have a great day, everyone.